Everybody, this is Dr. Nadeem. We are with Neelam Path Lectures, the Pursue series. As you are aware, all our lectures are available on YouTube. You can use the link to join the YouTube lectures. You can subscribe our channel there. And we have a Telegram group. You can join the group to access all lecture related information. We also have a Google Drive where the PDF of all lectures are available. And we have the master integration key by which you can navigate between the PDF and the YouTube. These are the disclaimers. And this is the phase 3 part of our series, which is convenient for the teachers, the students, and the organizers. As you are aware, the phase 3 is all recorded pathology lectures. And today we have Pursue 23I, which is genetic disorders, and we are streaming from AIIMS, Bhubaneswar, India. And the topic of the day is single gene disorder with non-classic inheritance and molecular diagnosis. And to talk on that, we have Dr. Amit Kumar Adhya, who's an MD from PGIMER-Chandigarh. Presently, is a professor in the Department of Pathology and Lab Medicine, AIIMS, Bhubaneswar. He has been the ex-professor of Kalinga Institute of Medical Science, Bhubaneswar, with 118 publications in international and national journals, 1 book chapter, 6 funded projects, 21 years of teaching and research experience. He has completed 5 collaborative research projects funded by DBT and BRNS, and has been awarded the Best Paper Award in the IAPM 2005. With this, I would request Dr. Amit Kumar Adhya to start his lecture on single gene disorder with non-classic inheritance and molecular diagnosis. Over to you, Dr. Adhya.
This is the last lecture in the series of genetic disorders. Here I shall discuss about the single gene disorders with non-classic inheritance, and I'll talk a few things about the molecular diagnosis. As I have already mentioned, these are disorders which involve single genes, but they do not follow the Mendel's laws of inheritance. This includes 4 different categories of disorders: the trinucleotide repeat mutations, mutations in mitochondrial genes, genomic imprinting, and gonadal mosaicism. Let us first talk about the trinucleotide repeat mutations. In fact, at least 40 different trinucleotide repeat mutations are known, but most of them are quite rare. I shall only talk about one of the disorders known as the Fragile X syndrome. The Fragile X syndrome is the second most common genetic cause of mental retardation after Down syndrome. This disorder involves a gene known as the FMR1 gene, which is located on the X chromosome. The incidence is 1 in 1500 among males and 1 in 8000 among females. If you perform a karyotype in these individuals by G-bending technique, that is by staining with Giemsa, you will find that some areas of the chromosomes are unstained. Those are known as the fragile site because they look as if the chromosome is broken at multiple places. Hence the name Fragile X syndrome. As I said, the FMR1 gene is involved and it is located in the short arm of chromosome number X. It involves trinucleotide repeats of CGG. In a normal individual, about 50 to 200 repeats of CGG are found. If an individual have more than that number of repeats, say in the order 200 to 500 repeats of CGG, then that person is said to harbor a pre-mutation. Pre-mutation because this particular 500 repeats is not sufficient to produce the disease. Hence it is known as a pre-mutation. If the number of repeats exceed 500, usually it can go up to 2000, it is known as a full-blown mutation. When a person has a full-blown mutation, he can manifest the disease. And the amplification of the CGG repeats occur during oogenesis. This is a very characteristic feature of this disease. The amplification, that is increase in the number of CGG repeats, only occur during oogenesis, but not during spermatogenesis. So the ova carry the mutation, full mutations, but not the sperms. On the other hand, there is another disease known as the Huntington's chorea. In that disease, the amplification of the repeat occur during spermatogenesis. That is also included in this category of disorders. The amplification of this repeat leads to methylation, which is an epigenetic change, and gene silencing. The FMR1 gene produces a protein known as the FMR1 protein, and this protein is most abundant in the brain and testes. Hence, these are the two organs which is frequently affected in this condition. Being a X chromosome related disorder, it does not follow the typical X-linked behavior of the Mendelian disorder. As you can see from the inheritance pattern here, both males and females are affected, and both males and females may be carriers, unlike the other X-linked recessive disorders. The risk of the phenotypic effect of this depends on the position of the individual in the pedigree. Another feature which characterizes Fragile X syndrome is anticipation. Anticipation means the phenotypic expression of the disease progressively becomes more and more worse with each successive generation, and the transmission is typically said to be from grandfather to grandson. The analysis of the pedigree chart of this syndrome will clarify some of these things. If you look at this pedigree chart, you will see that in this example, the male has got a pre-mutation. If the male marries a normal female, then these are the 4 possible outcomes. Because the female receives the X chromosome from the male, the female now becomes a carrier. But the male offspring receives the X chromosome from the mother, so the male child becomes normal. If this carrier female, let us suppose, marries a unrelated normal male, during oogenesis, this pre-mutation leads to further amplification of the trinucleotide repeats and becomes a full-blown mutation. Now in the subsequent generation of children, this X chromosome can be transferred both to the males and females. So the male here has got the abnormal X chromosome with the full mutation, so the male is affected. Similarly, this X chromosome can also be transmitted to the female offspring, so the female will also be affected by the disease. So you can clearly see from this pedigree analysis that the disease has been transmitted from the grandfather to the grandchildren. Moreover, the disease did not manifest in the first generation, rather it became severe in the subsequent or second generation. That is what is termed as anticipation. Further, you see that both male and female can be affected, and both male and female can become carrier. This is distinctly different from the normal Mendelian principles. These patients usually present with mental retardation, and the IQ level is around 20 to 60. Again, these patients have a very typical facial appearance. They have a long face, a large mandible, and everted ears. A very characteristic feature in this condition is macroorchidism or large testicles. 90% of the patients will have large testicles, of course, male patients. In addition, these patients will show hyperextensible joints and high arched palate. Also, these patients may show mitral valve prolapse. That was Fragile X syndrome. Another member in this category of disorder are the mutations in the mitochondrial genes. We all know that DNA exists within the mitochondria as well. These mitochondrial DNA actually have 37 different types of genes, and most of them encode for the mitochondrial enzymes which are responsible for oxidative phosphorylation. The organs where there is high demand of ATP, like the central nervous system, skeletal system, liver and kidney, are usually the organs which are affected when there is a defect in the mitochondrial genes. These patients usually show a phenomenon known as the threshold effect. Threshold because some of the organs in the body, as I said, the skeletal muscle, liver, they require more mitochondrial activity. But whereas the other organs do not require a lot of mitochondrial activity. So when a minimum level of loss of mitochondria occurs, these organs tend to be affected, whereas other organs are spared. This is what is known as the threshold effect. That means a minimum threshold level of mitochondrial loss has to be reached before the symptoms appear. Moreover, the expression in these mitochondrial defects have a very variable. These patients have variable expression. The best example of this kind of mitochondrial gene disorder is the Leber hereditary optic neuropathy. These patients develop optic neuropathy, that is pathology of the nerves of the eye. Usually the onset is around 15 to 35 years of age, and patients progressively develop blindness. Some patients also develop cardiac conduction defects. The inheritance pattern of these mutations is also very characteristic. They are said to have a pattern of inheritance known as the maternal inheritance. That means these defective genes can only be inherited from the mother. They cannot be inherited from the father. This is so because most of the mitochondria is present in the ovum. The spermatozoa lacks mitochondria, or the mitochondrial genes are very few in the spermatozoa, whereas most of the mitochondrial genes that we inherit from our parents come from the mother or the oocyte. Hence, the inheritance of this defective gene can only be transferred from the mother to the offspring, not from the father. As this, if you see this pedigree chart, this is quite evident. On the left side, if you see, if an affected male marries a normal female, then none of the offspring will develop the disease. This is because the spermatozoa will not transmit the mutated DNA. But on the other hand, if an affected female marries a normal male, then all the offsprings are affected because all of them get their mitochondrial DNA from the oocyte. Again, if this affected male marries a normal female, then the disease vanishes again. Whereas if the female marries a normal male, then all the offsprings are again affected. This is a very peculiar pattern of inheritance, very characteristic of the mutations of the mitochondrial genes, and it is known as maternal inheritance. The same thing is written here. Next is a disease known as genomic imprinting. Now, imprinting means selective inactivation of either the maternal or paternal allele. We all know that for each phenotypic character we have two alleles. One is derived from the mother and the other from the father. Many of these alleles are imprinted or become inactive. In fact, in a normal cell, about 200 to 600 genes or alleles are imprinted or inactive. That means either of the paternal or maternal gene is only active. Maternal imprinting refers to transcriptional silencing of the maternal allele, whereas paternal imprinting implies paternal allele is inactivated. And this imprinting usually occurs either in the ovum or in the sperm and happens before fertilization. This imprinting is again an epigenetic phenomenon, and it is mostly due to methylation of the DNA in the CG nucleotide or deacetylation of the histone H4 protein or methylation of the histone H4 protein. The best example which represent this kind of disorder are the Prader-Willi syndrome and the Angelman syndrome. Let us try to understand what are these syndromes. This picture shows two chromosomes. The chromosome number 15 is in fact depicted here. One is the maternal chromosome number 15 and the other is the paternal chromosome number 15. Under normal circumstances, these chromosomes contain two genes, the Prader-Willi gene and the Angelman gene. But only one of these genes is active due to imprinting. On the maternal chromosome, the Prader-Willi gene is imprinted and Angelman gene is active. Whereas on the paternal chromosome, the Prader-Willi gene is active and Angelman gene is imprinted. So a normal individual has only one copy of active Angelman gene and Prader-Willi gene, which is present either on the maternal or the paternal chromosome. So no disease is manifested. But it may happen that a deletion affects the maternal chromosome. So if a deletion occurs here in the maternal chromosome, then both the alleles will be lost. The patient will be left with only one active Prader-Willi gene and one imprinted Angelman gene. The active Angelman gene will be lost, so this patient does not have any normal copy of Angelman gene and the patient develops a syndrome known as Angelman syndrome. On the other hand, if deletion affects the paternal chromosome, the reverse will happen. The resultant offspring will have one imprinted Prader-Willi gene and one active Angelman gene, and there is a loss of the active Prader-Willi gene due to deletion. So this patient present with Prader-Willi syndrome. This may look very confusing at the first go, but if you listen it again, the things will be more clarified. So basically, Prader-Willi syndrome will occur if the paternal chromosome number 15 undergoes a deletion. The deletion will remove the active Prader-Willi gene, and the other Prader-Willi gene which is present on chromosome number 15 is normally imprinted. So both alleles of the Prader-Willi gene are now lost and the patient develops Prader-Willi syndrome. On the other hand, if there is a mutation in the maternal allele, then the patient is left with one inactive Angelman gene which is imprinted and the other Angelman gene is deleted. Hence, there are no normal Angelman gene in this patient, so the patient develops Angelman syndrome. The same thing is depicted here. So Prader-Willi syndrome is due to deletion of paternal chromosome 15, whereas Angelman syndrome is due to deletion of maternal chromosome 15. Both of them present with mental retardation, but there is some difference. Like the Prader-Willi syndrome is usually due to a loss in the small nuclear RNA, whereas the Angelman gene is due to loss of a gene known as ubiquitin ligase. Another issue with Prader-Willi syndrome is that it can develop due to uniparental disomy. Uniparental disomy means both chromosome number 15 are derived from one parent. Under normal circumstances, one chromosome is derived from the father and the other from the mother. If a person derives both the chromosome number 15 from the mother, then this condition is known as uniparental disomy, and this will lead to Prader-Willi syndrome. If you go back and look at the picture again, you will understand why the loss of paternal chromosome will lead to Prader-Willi syndrome. Similarly, Angelman syndrome can also occur due to uniparental disomy of the paternal chromosome number 15. As I said, both of these disorders present with mental retardation. The Prader-Willi syndrome, in addition, produces short stature, obesity, and hypogonadism. And these patients have profound hyperphagia. That means they always want to eat. Whereas the Angelman syndrome, these patients have mental retardation as well as a ataxic gait. Ataxia means there is an abnormal gait and the patient appears like dancing while walking. And these patients usually have a very inappropriate laughter. They laugh at everything and very inappropriate manner. Hence the name happy puppets. They walk like puppets and they are always happy. Next disorder is the gonadal mosaicism. I have already discussed this in the class, the example of which is osteogenesis imperfecta. These patients usually have normal parents, and mutation occurs in the parents in the embryonic life and preferentially in the gonadal cells, not in the somatic cells. So when the mutated germ cells are transmitted to the offsprings develop the disease known as osteogenesis imperfecta. However, the parents are not affected. This condition is known as gonadal mosaicism because the patients have one set of normal chromosome containing cells, which are the somatic cells, and the gonadal cells have abnormal chromosome. That was about the single gene disorders which do not follow the classical Mendelian principles of inheritance. Now we turn our discussion to molecular genetic diagnosis. Most of the indications of molecular genetic diagnosis are these four. You can use molecular diagnosis for prenatal testing, postnatal testing, diagnosis of cancer, or diagnosis of infectious diseases. Prenatal means testing before birth. Why would somebody like to do that? Basically, it is done when you suspect a chromosomal or genetic abnormality in the fetus. So, if you can detect the abnormality in uterus, then you can actually give the option of abortion to the parents. The fetus can be aborted and thus an abnormal childbirth can be prevented. That is the main aim behind prenatal testing or testing during pregnancy. But again, the legal gestational age for medical termination of pregnancy is up to 20 weeks. So the diagnosis has to be done well in advance of 20 weeks of gestation to go for medical termination of pregnancy or abortion. The various methods are available, which are amniocentesis, chorionic villus biopsy, umbilical cord blood testing, and liquid biopsy. Amniocentesis, as the name suggests, in this the amniotic fluid from the uterine cavity is aspirated and tested for chromosomal abnormalities. This is usually done at 15 to 20 weeks of gestation. The amniotic fluid contains cells floating within them, and the cells are derived from the fetus. The skin epithelial cells of the fetus are usually present within the amniotic fluid. So at 15 to 20 weeks gestation, if a chromosomal abnormality is suspected, then under the guidance of an ultrasound, the needle is inserted into the amniotic cavity, taking care that the fetus or the placenta is not injured by the procedure, and some amount of amniotic fluid is aspirated. The cells or the fetal cells from the amniotic fluid are centrifuge separated, and the DNA material is extracted and tested for chromosomal or DNA abnormalities. Apart from detection of chromosomal disorders, amniocentesis can also be used for doing a lecithin-sphingomyelin ratio. This is usually done to assess the maturity of lung. Normally it should be more than 2:1. If less than that, it indicates immaturity of the lung. Sometimes glucose level estimation can be done from the amniotic fluid. When there is an infection, the amount of glucose present in the amniotic fluid reduces. So it is an indirect evidence of an intrauterine infection, bacterial infection. RH incompatibility can also be diagnosed. Sometimes there is polyhydramnios in the patient, which refers to increase in the amount of amniotic fluid. So decompression of the uterus can also be done by the method of amniocentesis. So this is both diagnostic as well as a therapeutic procedure. Another method of intrauterine detection of chromosomal abnormality is chorionic villus biopsy, where under the ultrasound guidance, a probe is inserted through the vagina, or it can also be inserted percutaneous, and a portion of the placenta is sampled, taken out. Because the placenta is also part of the fetus, the cells in the placenta are the same as the cells of the fetus. So you can assess the chromosomal abnormality within the placenta. This can be done as early as 10 weeks of gestation, much earlier than amniotic fluid examination. So it's a better method, but it runs the risk of injury and hemorrhage. Most importantly, this is done for detection of chromosomal disorders, but neural tube defects can also be diagnosed by this method. Another method option available to us is cord blood sampling. An syringe and needle can be directly inserted into the umbilical cord under the ultrasound guidance, and blood can be aspirated from the umbilical cord. This blood belongs to the fetus. So it contains fetal cells. So the fetal DNA can be extracted from these fetal cells, and karyotyping and other things can be done for detection of chromosomal abnormalities. But the disadvantage of this is that this can only be done after 20 weeks of gestation, which is past the legal age of medical termination of pregnancy. Another new method is known as a liquid biopsy. It is known that within the maternal circulation, some of the fetal cells, they escape through the placenta and move into the maternal circulation. Either the fetal cells or fetal DNA or fetal RNA can be detected within the maternal circulation. So the maternal blood is taken and the fetal DNA or RNA material is removed and tested. This is more done for detection of cancer cells rather than prenatal diagnosis of chromosomal abnormality of the fetus. The cancer cells, they release DNA, RNA into the circulation. Even intact circulating tumor cells are released into the circulation, and apoptotic bodies, that is dead cells, are also released into the circulation or in the blood, which can be isolated and used for diagnosis of cancer. Postnatal testing or testing after birth can be done for multiple reasons. If a baby is born with multiple congenital anomalies, you would like to know what are the chromosomal abnormalities involved. If there is a suspicion of any metabolic syndrome in the children, or the patient is suffering from mental retardation or developmental delays, then you would definitely like to know if there are any chromosomal aberrations. If suspected aneuploidy, for example Down syndrome, then also you need chromosomal diagnosis. Molecular testing is also very commonly used for management of cancer. Most importantly, it is used for diagnosis of cancer because some of the cytogenetic or chromosomal abnormalities are very specific and diagnostic of a given cancer. For example, the BCR-ABL translocation is the hallmark for chronic myeloid leukemia, and this is also known as the Philadelphia chromosome formation. You might have heard about this Philadelphia chromosome. It is basically the translocation involving chromosome number 9 and 22, giving rise to a fusion product known as BCR-ABL. Sometimes determination of clonality is essential. Clonality means all tumor cells, they are derived from a single cell. That is known as a monoclonal. That is from a single cell. Whereas non-tumor proliferations usually are polyclonal. That means they are derived from multiple different clones. So monoclonality is a sign of cancer. Sometimes after diagnosis of cancer, you need to know whether a particular treatment or therapy can be given to the patient. You will know in detail about all these things later on, but for now just remember that few molecules such as EGFR, which is epidermal growth factor receptor, HER2/neu and BCR-ABL are targeted. There are drugs available which can target these molecules and used for treating cancer. After treatment, you want to know whether some of the cancer cells are still living in the body or not, and that is known as minimal residual disease. Usually minimal residual disease occurs in leukemias, and for the detection of minimal residual disease, molecular techniques are usually helpful. Drug resistance is another issue in case of malignancies, and many mutations are known to impart drug resistance to cancers. A diagnosis of these mutations can also be effected by molecular diagnosis. A lot of methods of molecular diagnosis are there. Many of them are given in some detail in your book, but most of them for your purpose is not necessary to know or remember right now. If you are interested, you can go through the book and we can discuss it later on. Here I have only enumerated the most common molecular tests used for diagnosis. Next generation sequencing is the latest of the molecular tests. As you know, Sanger sequencing was the initial type of sequencing. Now we have reached to a stage where we are mostly using next generation sequencing. Just remember the name and that will be sufficient for you for the time being. Thank you so much.